Hey, where are you, mate? You're at the other side of the world at the moment, is that right?
Yes, back home in Norway for a quick trip, a wedding, and so forth. But with technology, we will not miss another week of the Pre-Hospital Nerds podcast. And yeah, we could do this remotely, record, get some thoughts out there, and hear what people have to say about cervical spine immobilisation, CSI. What do you reckon?
It's a pretty interesting topic. It's something that pre-hospital clinicians have done routinely for a long period of time now. So it is the golden standard. Anybody with a suspected, good mechanism of injury, stick on the hard collar, strap them to a board, strap them to a bed, and zoom them off to hospital thinking the worst. But times have changed, Alex. There's things out there and places out there that have moved away from the semi-rigid collars to now a soft collar. What are your thoughts about that?
Solutions are often the cause of most problems, and I think people have concerns that these hard collars in years gone by have caused more harm than good. So I think the first thing to say is that the sort of incidence of traumatic spinal cord injuries are very low. But, the very few that do have a cervical spine injury, they need as much protection as possible. And a hard collar is, the best way. It doesn't completely eliminate movement, but is there. But then there's 99% of people with a low mechanism injury who don't have a cervical spine injury, but who get treated as a suspicious one, and they get fitted with all these hard collars. And if they were without harm, I think that would still be the practice. But the fact that they constrict the neck, reduces cerebral venous return, increasing ICP, causing pressure sores, etc., there's reason to question this practice. What do you reckon, mate? What time did all this sort of change within your ambulance service?
It has varied, and there's been a bit of research out there about, whether people should be wearing semi-rigid collars or whether they should be going to soft collars. And certainly within Australia, a lot of the ambulance services now have moved away from the semi-rigid collars and gone to the soft collar. They notate on the collar that the cervical spine has not been cleared as a secondary reminder for the clinicians at the hospital to ensure that they maintain cervical spine immobilisation. But yeah, so it's probably it'd be the last 4 years, 4 or 5 years, I would say, that it's actually been occurring. Now, it's interesting. I still work obviously in the pre-hospital environment now, and I work at various events and so forth. And I was fortunate to work at one of the rugby events just recently. And we're talking international rugby, so not local rugby, we're talking international rugby. And the medical team from the rugby are still very insistent on the use of hard collars. And I believe that is a standard within the international rugby community that hard collars must be applied in the first instance. I don't understand completely the thought process around it. There is some research out there backing them, the reduction in the movement of the whole body with a cervical collar. However, as you've already stated, it does have its associated complications with wearing a rigid, semi-rigid collar, and that is discomfort's probably one of the biggest things. And then also, you go to the rugby, and we're talking about people who are, minimum weight of 100 kilos, most of them, and have got necks which sort of extend from their trap straight to their ears. And so trying to actually fit a semi-rigid collar around them is pretty much missing impossible, on its own. So the movement to a soft collar is actually probably beneficial in those patients. Can you think of anything or any issues that you can get with wearing collars? When we transport patients in the back of a ambulance and we immobilise the spine, what sort of issues do we potentially run into?
Well, I think one big thing would be sort of vomiting. If you've restricted the neck and they're lying there doing 80 Ks, 100 Ks, moving the other way, and you're already a bit sort of sick or sore under the weather, certainly sort of aspiration, pneumonia would be a concern, of course, if they're lying there restricted. Whereas if they were a bit less restricted or less concern about the potential C-spine, then people would move freely, get some of that vomit on the floor instead of the lungs. I mentioned before the increased sort of intracranial pressure, with the hard collar, tight restriction around the neck, the veins that drain all the blood from the head, and struggles to come down. And I think that's a particularly important point in patients who have a concurrent TBI, traumatic brain injury, because oftentimes there's a bit of a trauma mechanism, and well, we go to put a collar on, but probably their main problem is a brain injury, in which case raising the ICP is not a good idea. So yeah, that'd be a couple of things that comes to mind.
A good point. I'll jump in there, mate, about the ICP concern. That's a really good point. And so if you've got an isolated head injury, so somebody's taken a knock on the head, it's not a multi-trauma patient, so they haven't got busted ribs, busted pelvis and all the rest of it, but they've taken a knock to the head. It's clearly an isolated head injury. The big thing that you can do, obviously, is elevate the bed slightly. You're concerned about a cervical spine injury. You are maintaining thoracic and cervical alignment, but you can bend them up slightly. So you can bring those patients up to, 25, 30 degrees and actually still manage their cervical spine and maintain inline immobilisation with them as well, which is really important, because just because you put a collar on does not mean that you need to lie them flat. Each patient has to be taken into consideration as to what's actually caused their mechanism of injury, but it's something to consider. If it's an isolated head, then you can raise it a little bit, especially if you're concerned about an ICP. That's a really important factor.
Yep. You'll probably find some guidelines and protocols around places say, patient has to be flat until the C-spine is cleared. But yeah, no, that's a good point. Yeah, with this isolated traumatic brain injury,
it's certainly something to One thing I want to talk about, though, Alex, is presentations on patients with cervical spine injuries. I've been to countless patients who have suspected spinal cord injuries or suspect a mechanism for an injury to the cervical spine. And so everybody puts on a collar. Now, from my personal experience, from my presentations that I've encountered, those people with a true cervical spine injury have declared themselves initially at scene, or they've had ongoing neurology, which has made it evident that a cervical cord injury or cervical spine injury has actually occurred to them. People can get cervical fractures and they can be stable, which is the other thing that we need to think about. So patient's presentation is they've fallen over, they've banged their head, they've possibly got a fracture to their spinous process, but it may be stable. And so they may still be walking around and so forth. And this is maybe a common presentation we get with elderly patients, is they have a cervical fracture from a minor injury, but actually it's fairly stable and still they're functioning as per normal, doing their normal activities. And it's not until later on that they go, I actually am really quite sore in that one spot, or tender on palpation, that they actually get sent off for further management and so forth. Patients who fall over and bang their head and immediately say, I've got altered sensation in my arms and legs, my suspicion goes through the roof. They're the ones that I'm going, righto, well, we will put you in spinal immobilisation. We will limit your movement as much as possible. And then there's other patients that you go to that, a football player that's banged their head. Yes, we're concerned about cervical spine injury as well, but commonly it's associated with just a head injury and maybe not so much neck injury and no neurology and anything like that. So one of the important things that we need to think about, and especially nowadays in the pre-hospital environment, is occupational health and safety issues that we can encounter. And one of those issues is moving patients in the pre-hospital environment when they weigh 120 and 130 kilos. And their mechanism of injury is low. They don't present with any neurology. They don't have any neck pain or discomfort. And you need to move them from inside the car to a stretcher. What's your thoughts on telling them to get out and move themselves, Alex? Putting you on the spot with that one.
Is it done? Yeah, should it be? Is that, it's off. I'll put on the spot.
I'll tell you what I think, Alex.
Look, if they don't, so they're sitting in the car.
Yeah, so bang, head-on car accident, maybe 50 k's an hour. There's no smashed windscreen. no bumps on his head, hasn't had a LOC. But the crews go, whoa, mechanism, 60 k's an hour, bang, bang, bang. They've banged into each other. Still trapped to the car, mechanically trapped, not physically trapped. So the car's just squashed in a bit. They can't open the door. Am I painting a good picture?
Yeah, beautiful. And it's buying me time to think about my answer. It's good. Yeah. So what? And then you sort of do a gross neuro exam there. Any tingling, any weakness? They're fine. They're moving all four limbs, and they don't complain of any pain. I presume the practice is that these people are walked out, placed on a stretcher, and then advised, due to mechanism, we better now protect the C-spine.
I reckon you were probably
Tell me if I'm wrong.
pretty spot on there, Alex. And I think, people who have got injury or pain to their neck often self-splint. And I think that's probably one of the big things. Like if you hurt yourself, you will do things to protect it, to stop it moving and so forth. So if you break a bone in your neck, more often than not, it's actually going to cause a little bit of pain or discomfort. And so you will self-splint. And if you don't have obvious neurology or anything like that, then sometimes patients can move themselves and self-splint and actually get themselves out of a vehicle and onto a stretcher.
Yeah, true.
If you've got any neurology or anything like that, or a really high suspicion, then all bets are off. You do everything you can to immobilize them as much as possible. We have to think.
That's where they come to the jaws of life. And lift the roof off the car.
Yep, absolutely. I mean, we have to be mindful of people's, the first responders and their own health and fitness as well, because responding and dragging people out of cars, I don't know if you've ever watched it. It's not a very, what's the word for it? It's not a very pretty process. Like the physical manhandling that you need to do of a patient to actually physically get them out, and especially if they're unwell, trying to do that rapidly without, putting yourself at harm or the patient at harm in doing so can actually be quite hard. So it's important that, if there is that option that the patient doesn't have neurology, has got no neck pain, or is able to get them out by themselves without causing any pain or discomfort, then that may be the easiest option. I'm not saying blanketly, yes, that's what you go and do, but each case needs to be put up on its own merits and consider whether self-extrication is the best way for that person to get themselves out.
Yeah. And part of that equation is remembering the primary survey. What comes first in the primary survey is D, And I think a few times you have to do it based on dangers. And I attended an event recently, a horse race, and the jockey fell off and complained of some neck pain, and we were, obviously suspecting a spinal cord injury. You got sort of suspected in those cases, high mechanism and pain. But the horse was injured and, very close by and kicking around, and the vets advised we have to move the jockey. So whilst I would have loved to sort of, immobilize the spine, get a spine board, get him away, he stood up and walked away, and then later laid down in the back of the ambulance. We immobilized him. And thankfully he didn't have a cervical spine injury, but it was a lesson learned.
It's a hard decision to make sometimes. And I think, you have to weigh up the patient's clinical presentation, the mechanism that's actually caused the injury to the patient. That's probably one of the big things that sways me a lot of the time. The age of the patient, obviously elderly patients can fracture and break bones a lot easier than what the young patient can. So you put all those things into context, you weigh up all the information, you make your own clinical decision as to whether you feel it's important to apply it immediately, or whether you feel that the patient can splint, manage self-support to get themselves from wherever they are onto a stretcher, and you can support their immobilization that way. Something that you need.
Yeah, good. The more I think about it, like the terminology suspected cervical spine fracture, or, the neck, it catches too many things. I think, there should be a group for those with the mechanism and neurology. Everyone knows, this is high risk. And when they come to hospital and we do CTs and stuff, if there's ongoing neurology, meaning, tingling or weakness. Even if the CT is fine, showing no fractures, they'll often get on to getting an MRI because you can sort of get ligamentous injuries. And so that's the highest risk group or highest likelihood. Then you got the group with pain. And I think there's a whole group which is just done out of tradition or based on mechanism, or you can't clear them, sort of clinically you can't assess them because they're drunk or GCS is reduced, or so yeah, there's a few groups. Maybe we need to tighten up the language a bit.
Well, I think that's another interesting point you start bringing into the conversation there, and that is the patient who is an altered conscious state, applying a cervical collar to them. Because it's all very good and well that you say, well, they're drunk, so I need to put a collar on you. But putting a collar on and immobilising somebody who's got a belly full of beverages from the evening out, and then driving them around in the back of an ambulance, staring at the roof and wobbling is guaranteed to bring on emesis. Once again, you've got to apply a bit of common sense and look at the mechanism and all the rest of it. And sometimes for safety reasons, those patients could actually end up needing to be intubated, because if there's a high mechanism with a moderate head injury of some sort, and there is a high potential for vomiting and so forth, then that may be a need for airway protection and cervical spine immobilisation, which you may not be able to do if the patient is not behaving themselves. So it creates another issue and another drama for you as well. So depending on which ambulance service that you work for, there may be the need to consult for the authority to perform intubation on that patient for airway protection and cervical spine immobilisation and protection.
Yeah. Yeah, nice. So that's a bit about the presentation. So how do patients with a cervical spine injury present? Pain. Yeah, everyone's got pain, but this is sort of pinpoint midline pain. It's most likely to be related to any sort of fractures or C-spine injury. And then we mentioned neurological symptoms, weakness, tingling. And on exam, anything you find there?
Well, I think, ultimately it's once again comes down to true spinal cord injury or patients with a suspected fracture of a bone in their neck. Because obviously you can break a bone in your neck and not have neurology. So that's an important thing to remember, that you can break parts of your bone but actually have no neurology. But if you break a bone that's causing neurology and symptoms, then there's things that obviously we look for. And, in the pre-hospital environment, we look for pulcheothermic, which is hard to recognize sometimes. So the body adapts to the external environment, and in the immediate environment, you're probably not going to recognize it instantaneously. Irregular respirations is probably another good one. So diaphragmatic respiration, so watching their breathing pattern. And that's really important. When you talk about breathing pattern, you look at things, we'll probably talk about this after as well, but end-tidal CO2 monitoring, because you may be giving them oxygen or putting a pulse oximeter on and they're getting reasonable oxygen saturations, but they're probably not expiring as well as what they normally should. And so that if you watch their end-tidal, you may find that it steadily creeps up and up and up and up and up. So, that's another thing that you need to watch for. What else? Hypotension. The true spinal cord injury has got significant hypertension, bradycardia, sweating and so forth as well. So there's quite a few things that you can recognize. Altered sensation in the limbs, that's the big one, being able to mark which dermatome the patient loses the sensation from, really important things. But at the end of the day, for me, the biggest thing is having the suspicion and then doing the immobilization and transporting. If you can't work out what dermatome it is, that's fine. That's fine. Just say from the nipple line or from just below the nipple line or around the belly button or wherever. He's got altered sensation in his little finger and his ring finger. Sort of those things, if you hand that information over to the clinicians waiting at hospital, it'll give them a good picture about what's actually going on. So I think if you can talk about what you see in front of you and hand that over the radio as you're driving towards the hospital, that'll give them a good picture and prepare themselves appropriately for you coming in.
Yeah. Beautiful. What about reflexes? Do you check them pre-hospital? Should we? Or are we adding too much? I always got to throw it in there. Every podcast, a little a little assessment tool that the could be done, but probably doesn't change much. But if you tap on the patella to assess the reflex. And
So I'll get this one back to you, Alex. If the patient's lying supine on the bed, how are we going to test his reflexes and his patella?
yeah, oh no, well, yeah, well that challenge could be solved. Just sort of cross the legs over and get out the stethoscope, tap on the patella there. Look, they are done in hospital, but again, I'm not sure how much they changed. I mean, it's a part of the language when you ring in and consulting with all the specialties, and if someone's got an injury and we got to call neurosurgery or spine team, you got to do a detailed sort of neurological assessment. But the problem is that sort of hyperreflexia could be a sign, but also absent reflexes could be a sign, and it takes a bit of training to get it, and then people have various levels of reflexes to begin with. But look, I guess if you had time and in the back of the truck on the way in, just cross the legs over and drop a stethoscope on the patella and see. But that said, you're not testing all the nerves that way. So if you got to do a sort of thorough neurological exam, you got to check all the upper limb and lower limb reflexes. We'll steer clear of pre-hospital reflexes for the
I
time
think
being.
you would find that majority of clinicians in the pre-hospital environment, and I'm sure there are a few out there that actually do it, but I would imagine that the majority of them don't. In some services where you have pre-hospital physicians that are attending to patients, maybe that will be part of their assessment because they're familiar with it. But I think in the majority of pre-hospital clinicians transporting a patient to hospital, the question will be, how is me banging on a tendon going to change what I do for this patient? And the answer will be, it won't. All it will do is provide a little bit of further information for the receiving clinician at the other end, but also they will repeat that procedure anyway when they get to hospital to test for themselves. So I like it. Good question, and good to bring in the hospital side of things. But I don't know if banging on tenders in the pre-hospital environment will change much for us.
No, I agree, but I think the sort of the flow chart is, are you going to leave them at home?
Yeah.
This is the way it's got to be sort of with pre-hospital stuff. Like if the decision is transport and that's been made, no worries, focus on pain and hemodynamics and, don't do any unnecessary stuff on the way in. Same we spoke the other week about syncope, cardiac auscultation. Does it have to be done? The answer is no if you've made the decision to transport. But if someone's passed out, then and you're going to leave them at home, then probably some of these more tests are required. And to bring it back to this stuff with cervical spine, I mean, if it's a low mechanism and doesn't sound like much, they don't have pain, and you're going to leave them, it wouldn't hurt to sort of to do a couple of reflexes, I would have thought. But
yeah,
what do you reckon?
Well, I think you're quite reasonable with what you're saying. I think more importantly, the main thing for me would be testing for sensation. Obviously, all their limbs got good sensation and normal movement and normal strength throughout all of their limbs. That would be a big thing for me from the start. And with any associated pain and discomfort. And so a good palpation of the patient's neck, whether you've got cervical spine rules that you follow for your ambulance service to determine if somebody, fits the criteria for a collar or not. So assessing those sorts of things, putting your picture, your mechanism of injury, the age is the biggest one for me. Alex, elderly patients break bones much easier. So falls have a higher suspicion with those elderly patients as opposed to the younger patient that bangs their head. Not saying they don't get injuries, but they're less likely than what the elderly person will. So high suspicion for the elderly. Did I get that across enough, you reckon?
Yes.
Yeah, good.
Yeah, well, yeah, you bring it up, so let's just talk quickly about special populations. So elderly, they're osteoporotic and on steroids and all sorts of reasons to break the neck. So even a low mechanism fall, or particularly for me, that sort of frontal impact, I worry about a high cervical spine. If they've come down and hit the front of the head, something's transmitted through to the back. So yeah, worry about the elderly. But then you mentioned kids and pediatric population, they're very unlikely to
They bounce.
cervical spine.
They bounce. They do bounce. They seem to do very well. But once again, don't dismiss it. You can't just say because the kids, they won't break the neck. They do obviously break the neck. With enough mechanism and enough force, they will break bones just as well as what adults will. The chances and the likelihood statistically is less common than the elderly patient. Other things you got to look at, bone disorders, the osteogenesis imperfecta or something like that. People with pre-existing bony injury, kyphosis or illness, or you mentioned osteoarthritis and so forth before, anything that can affect a patient's normal body condition puts them at a high
Osteoporosis.
Yeah.
Osteoporosis, weakening of the bone, yeah. As opposed to osteoarthritis. Yeah, no, look, they're good. Any other past history? What about ankylosing spondylitis? Look, it's rare, it's out there, but just an inflammation of the spine, and they would probably be at increased risk of fractures. So, good, mate. So that's a good rundown of cervical spine. So what's the sort of TLDR? There's a few different groups. The ones just with pain, the ones with actual neurology, and then a huge group of people with a potential to break the neck. But I mean, everyone's got that potential. I turned ahead too quick, So we should think of the groups, I guess, a bit more separately than all fall under this potential C-spine injury, and everyone needs a collar.
I think the decision, once you decide to put a collar on, your management should be pretty much the same for your lower suspicion through to your high mechanism with neurology. Because if you're putting a cervical collar onto a patient, you're going, I am concerned about this person's cervical spine, so much so that I am going to immobilize them on the bed and I'm putting them at risk of aspiration, nausea, pain, discomfort, all those sorts of things because of your suspicion. So it may only be a low mechanism and all the rest of it. You go, I'll just put a collar on just in case. But when you make that decision, you're making a decision that this person is now going to be immobilized, has the potential for pressure sores, has the potential to get nauseated and vomit and then aspirate as they drive to hospital. So it's actually more than just, I'll do it on because the hospital will give me a hard time when I get there. You've actually got to think about there's more consequences to it than just applying a collar. So once you put it on, I think the management becomes the same. I would always be suggesting an antiemetic for those patients, especially driving around in the back of an ambulance. Just the collar alone is not enough. If you're thinking about cervical spine injury, I'll be putting head rolls next to the patient's head. Then, people being on spine boards. Now, I know spine boards are not used as much as what they used to, and the process nowadays is that we try and remove the patient from a spine board as early as possible because of the pressure sores and the discomfort the patient will feel from it. However, if you are then in the back of an ambulance that's moving down a freeway at 100 k's an hour and you need to roll your patient in a hurry, your ability to maintain inline immobilization with that patient obviously falls out the window. You roll them on your side by themselves, then your inline immobilization will fall. And as soon as they start vomiting, that's what you're going to need to do is roll them. So I know in the back of the helicopter, when we fly them sometimes, if you've got a patient who's in a conscious state that's sort of 13 to 15, has had a head injury, has got the potential to vomit, we'll probably keep them on a spinal board so that you can rapidly turn them and keep inline immobilization. But bearing in mind, you need to be concerned about pressure points throughout their transport as well, and the issues that can cause by keeping them on that spinal board.
Yeah, great. We forgot to talk about research. This is where people will end the podcast. But what about research? Has anything been done in this space? Is it easy to do research on this?
Well, I think there's a bit of research, and then research is your baby, mate, not mine. And I know there's a lot of stuff that went around the time of the change, moving from semi-rigid to soft collars. There was a few papers that got produced. I believe there was one produced by your mate from the Alfred.
Yeah. Group there with AV looked at stuff, sort of the change from the hard to the soft collar, or semi-rigid, we should say, semi-rigid to soft collar, and no difference in cervical spine injury, but also I think it's important to say no difference in some of these harms. You know, we say that hard collars have the potential to cause X, Y, Z, but looking at that, there wasn't an improvement in that. Like the rate of pressure sores being very low, you know, it's 1 in 1,000 gets pressure sores, but the sort of rate of that in the hard collar or soft collar comparable, and same with pneumonia. It's hard to study the sort of ICP in a clinical setting. But I think with research and this sort of stuff, so people are always saying, well, there's no high quality evidence that it's effective and it might have all these risks. And then there's sort of observational studies that, you know, show, oh, well, the risks are pretty comparable. And it's very tricky to do research in this sort of stuff, you know, like when the incidence is so low, this is a needle in a haystack, like a true sort of spinal cord injury, but you can't miss it.
Yeah, you don't want to.
That means a lot of false tests, or, you know, like when you go to the airport and you go through the metal detector and the thing goes off and stuff. Like every person has to suffer through this invasion of privacy and radiation and whatnot just because 1 in a million will carry something through that they shouldn't. And, you know, I think of this as the sort of same thing. Like, there's very few that have a true spinal cord injury, yet sort of everyone's at potential risk of it if there's trauma involved, so they need to be treated with the greatest level of concern, just like any holiday goer needs to be treated as suspicious type thing. And then how to do research. You can't, like, to do a randomized controlled trial where you say half of the patients are going to get this and the other half's going to get the hard collar. That'd be very hard to get up. First, you got to show that it's sort of, you know, just as many benefits as harms. But then the size of that randomized controlled trial would have to be massive, you know, because the incidence is so low. And what happens then always is that, well, we'll do it international and multi-center and stuff. But then people sort of tend to argue that the results may not be applicable in our setting because the findings from this big international RCT had a lot of patients from elsewhere. So, yeah, hard to find an optimal solution. So what is happening is just people argue and implement some practice changes and then observe whether it worsened things or made it better.
Good.
I'll save the rest of the hour-long research lecture for another time, hey? Or do you want it now? Yeah, no, you want it now. I can hear it. You're ready. You got pen and paper ready. So, good, mate. I think that's what there is to say about collars. It's really what the podcast is about, rather than, well, we've touched on sort of the cervical spine assessment and management too. This was all in one. Good. Anything else? Yeah, go ahead.
Good on you, Alex. Enjoy the rest of your holiday, mate. Cheers.
Thank you too, mate. Peace out.
Bye.